Welcome to our latest live episode of Coffee, Kids, and Sports Medicine. We're really excited about today's talk, and I think we really put together a great program for you guys, as well as some really good speakers. The format will be a little bit different today. We do have a little bit of a panel discussion, so we're going to have these speakers kind of come through rapid fire and go through a quick talk, and hopefully have some time towards the end for some panel discussion and some questions. We're going to be covering debunking the myths in pediatric orthopedic sports medicine. Our speakers nor this program have any relevant financial disclosures. Our objectives are listed here for you guys to read. We're not going to go through those one by one, but they are here. Our speakers will come up and they'll introduce themselves just for the sake of time. We really want to try to get as much material and then, quite honestly, as much discussion as we can. So we certainly welcome questions and really would appreciate you guys sending those in. Don't forget to log in and scan your QR code so you can get your CME credit. And finally, really important for this talk in particular, these questions will be really important for this. So we welcome and really appreciate your input, questions, and commentary. So there's 3 ways to do this. You can do the text with this number here. You can send us a text question. You can log in through the email, or you can log in and use the live chat function in YouTube. So please get those questions into us, and we really hope this stimulates some good discussion. We appreciate it. Our first speaker today will be Dr. Shane Miller, and he's coming up now.
Hello, good morning. I'm Shane Miller. I'm a pediatric sports medicine physician here at Scottish Rite, and I'm going to be speaking on debunking myths in pediatric sports medicine and strength training today. I have nothing to disclose. So we're going to cover a few myths today, and hopefully by the end understand that these are in fact misconceptions, but here are some common ones that I have heard. Strength training will stunt your growth. Strength training is not safe for kids. Kids can't gain strength until they go through puberty. And there's a picture of me doing push-ups and when I was a little bit younger there, working out. So what is resistance training or strength training? You see here a group of high school boys working out at the gym, and often, don't see a whole lot of supervision or instruction and technique. And often focus on lift more, who can lift the most, how much did you lift? Well, I lifted more than that. Well, even though you lifted more than me, I'm going to try to lift more than that, even though I probably can't or shouldn't. And so that is resistance training, and that's often what people think of, especially as pediatricians or others who get asked, parents say, well, can my kids lift weights, or can my kids do strength training? Is it safe? This is oftentimes what comes to mind. And it's not always the big barbells and the Olympic style lifting, but it can be dumbbells. It can be different types of training. But what about this? Is this resistance training? You see a group of young girls here doing kettlebell training and working out and doing some techniques here as well. Is that resistance training? Or here, a young girl working with some resistance bands. Is that resistance training? Here body weight exercises. This young man's working on some squats and working on his technique and doing things with just his body weight. So the answer is yes, all of these are different forms of resistance training. So it doesn't always just have to be the typical weight room and kind of heavy lifting or powerlifting or bodybuilding or the other things that are traditionally thought of. And so as we start to widen our perspective of what resistance and strength training is, perhaps it becomes a little bit more clear that maybe these things are a little bit safer for children and perhaps beneficial. So resistance training is any sort of exercise training that may be designed to enhance muscular strength, power, and endurance. That term is often used interchangeably with strength training, and so it's, again, when people talk about weightlifting, that can be a particular sport, or they may mean actually going to the gym and lifting weights. But as you see, there's lots of other ways to do strength training or resistance training that don't involve lifting weights, and so it can involve very simple body weight movements, even at very young ages, and we'll talk a little bit more about that in just a minute here. So I'd like to guide you to a couple of resources. In a short talk this morning, I'm not going to have time to go through the details of a lot of the studies that support my statements here, but these are great resources from the American Academy of Pediatrics. Just in the past year, they've come out with this resistance training for children and adolescents clinical report that summarizes a lot of the most recent evidence and has all the references there. as well as the 2014 International Consensus Statement on Youth Resistance Training from the British Journal of Sports Medicine are both great resources for this topic. So just like with exercise, we find that there are a lot of benefits to resistance training or strength training. Of course, there's the gains in strength, speed, power, and endurance that you might expect, because that's the goal of doing resistance training. But there's also improved motor skill performance, whether that's sprinting, cutting, jumping. We have reduced injury risk. Sometimes we have specific programs designed to reduce the risk of injuries, such as ACL injuries that involve resistance training. Injury rehabilitation. We use this all the time, even in our younger patients and athletes, to rehabilitate and recover from injuries. Improvements in cardiovascular fitness, body composition, bone mineral density, insulin sensitivity, lipid profiles. Well, those all sound pretty good, especially with some of the population that we're dealing with, not only with obesity and some of the challenges there, but also on the other end. We have a real challenge with what some have termed exercise deficit disorder. And what's called dynapenia, where we have children who are not as active as we need them to be and don't have enough muscle strength to perform daily activities and really have long-term effects related to that. And of course, there's great mental health benefits associated with strength training. So myth number one, will strength training stunt your growth? Appropriately designed resistance training programs have no apparent negative effect on linear growth, growth plate health, or they don't impact the eventual adult height. So the answer is no. They don't stunt your growth, and there's no evidence that supports that myth that still is around, and it was around when I was a kid growing up and still has around. And actually, some of the stress placed on bones by resistance training, both in youth and childhood and adolescence, may actually be beneficial for long-term bone mineral density and bone development. So we think there's some benefits to that there. What about myth number two? Children and adolescents can gain strength with resistance training with low injury rates if the activities are performed with an emphasis on proper technique and are well supervised. And so I definitely want to highlight the proper technique and well supervised. We're talking about proper technique. We are talking about the actual form that they're using, the appropriate weight or resistance that they're using, controlled movements instead of just jerking it up and trying to get as much weight as they can. And then of course, well supervised. So this is not necessarily the home gym that, the child gets a set and puts in their garage and then works out for the first time, or unfortunately, sometimes even at the, the team environment where you get a lot of boys and kids together who may be challenging each other. And now we have lots of the middle schools and high schools are doing summer programs and such. And so the hope is that with, qualified professionals that are leading these, that we're actually getting a lot of the benefits without as much of the risks. And so, again, poor supervision, improper technique, and inappropriate progression of training loads do lead to increased risk, but otherwise we think that these are safe if done properly. So one question we get a lot is, what age can you start? And in the AAP statement, they say age is 5 to 7 is when many children are already starting sports, and it is reasonable that they can also benefit from strength building exercises at that time. But it doesn't mean that we're going to put them in the gym and have them lifting weights like those high school athletes might be, right? So this is maybe body weight movements and working on agility, balance, coordination, what we consider to be physical literacy. So frog jumps, bear crawls, crab walks, kangaroo hops, one-leg hops. As a very brief time when I was a virtual home teacher for my kids last year when we all shut down briefly for COVID, this was part of PE, trying to make it fun, try to get them active and doing some things that you can for strength building. So very capable of doing it at young ages. Myth number 3, kids can't gain strength until they go through puberty. Yeah, gains in strength are primarily attributed to increased motor neuron recruitment. So basically the muscles learn to fire more motor units at the time, so they become stronger. But you're not going to have the hypertrophy until they have increased androgens and go through puberty. So after puberty, it augments muscle growth by actual muscle hypertrophy, but prior to that, you get increased motor neuron recruitment. But I can assure you that if you spend a day in clinic with us and you see some of the young athletes that come through here, they are quite strong, even if they have not yet had the muscle hypertrophy and gone through puberty. So overall recommendations in terms of implementing strength training in the youth. Again, it really is important that the program is designed, by somebody who's qualified and has the background and the understanding to design a program based on the needs of the team or the individual, the goals, the abilities of the athlete. Each individual is at a different level, and it's really important to individualize the program even within a team environment. You want to emphasize proper technique and supervision. And oftentimes we really want them to start with no weight or minimal weight until proper technique is mastered. We don't want to get them in there starting with too heavy of a weight if they don't even know how to do the form correctly. A very basic sort of starting point would be 1 to 2 sets of exercises, 8 to 12 repetitions, and doing it a weight that they can handle fairly easily without fatiguing prior to that, so they can maintain good form, and doing that 2 to 3 times per week, and then gradually increasing from there. You want to perform complex movement exercises earlier on, and then build onto the simple movements later on in the exercise session. And you want to do upper body, lower body, core, and kind of have a mix of different exercises there for your program. So the take-home points from my talk are that this can begin really early. It says as young as age 5. I got home last night and my 4-year-old said, "Daddy, look, I figured out how to do push-ups." And he dropped down and did 5 push-ups for me. So it's not an age thing. It's really an individual readiness more than an age. And you can start strength training very young. It will not stunt growth. It's very important to focus on proper technique and supervision. And again, kids are not going to have muscle hypertrophy until they go through puberty. So here are some of my additional references. And I appreciate your attention, and I'll take some questions now if there are any.
Shane, I think there's a lot of great take-home points that moms and dads frequently ask a lot. And it's clear that it's safe. And so the myth is debunked, if you will. My question is as kids get to become more competitive, we know that strength and conditioning training in the high school athlete is very beneficial for injury prevention. But at what age should we start being a little bit more diligent about trying to balance their soccer practice and their basketball practice with a strength training program? Is there a time where we feel like injuries may start to creep up, or we should start considering adding that to some of our kids' regimens?
Well, that's a great question. And as we see, unfortunately, a lot of overuse injuries. And so repetitive movements of the same activities over and over again, lend, a lot of visits to our offices, as well as time lost from sport and injuries. And so, I really advocate incorporating some of these practices in early on. And again, with the emphasis on proper technique and supervision, learning how to train early on is very important, even if the emphasis isn't necessarily just on how much weight they can lift or the performance aspects of it. And this is not in addition to the amount of training that they're already doing and adding extra hours per week to the training where they already have overuse injuries. But I really wish that this would be incorporated more through coaches and teams into part of their training program. And around the time of the adolescent growth spurt, we often will see an increase in injuries. And so I think that that's a very appropriate time, if it's not already added, to have learned some of these techniques to help maybe get some of the injury prevention benefits as well.
Got it. And I have one more question for you. Are there any clearance exams or screening that you would recommend before encouraging a patient for a strength training program?
In general, most kids can start a strength training program without medical clearance. Now, if there is, significant, obesity or hypertension or some other medical issue or concern, then it's reasonable for them to get checked by a medical professional. But the majority of kids should be able to do this, and we wish that these were incorporated into, for example, physical education programs at schools, so that it's kind of being utilized by everybody. And even though I mentioned obesity, resistance training or strength training is actually one of the, it's actually a very favorable activity for those with obesity. And some of that is because they often, patients with obesity are actually very skilled at resistance training and strength training and maybe stronger than some of their peers. So it's something that they can excel at. And then it gets them involved in physical activity. They get a lot of mental health benefits from that. And then you start to incorporate in some aerobic exercise on top of that. And now all of a sudden you have an obese child who's engaged in daily physical activity and is enjoying it and perhaps developing lifelong skills. And so there are a lot of benefits, even with those with obesity, that we would like to get them engaged early on. So that most patients can go ahead and get involved in a strength training program without medical clearance.
And I have one more quick question that is probably going to be another talk at the next time we debunk a myth. But if you can give us a 1 or 2 liner about an age for use of supplements.
So yes, yeah, exactly. Supplements is a new topic altogether. And in general, we like for athletes to get the nutrients, the minerals, the vitamins, and what they need from their diet. And so, in general, we would try to encourage a well-rounded diet prior to recommending a supplement at a particular age. Thank you for your attention.
So good morning. My name is Rushi, and I am one of the sports physical therapists here at the Frisco facility. So today I want to talk about therapeutic taping, specifically in terms of like what the research and current data tells us on what therapeutic taping might or might not be beneficial for. So I have nothing to disclose, no disclosures. So first I want to kind of touch on like commonly held beliefs. So by no means is this an all-encompassing list. These are just some things I've heard from patients in the past and present, as well as some things that we in the rehab community, when we try using therapeutic taping on clients, what we potentially say might help for. Certain things like it can help prevent ankle sprains, it can help provide some joint stability, it might be able to decrease some shoulder pain when you're playing, especially for some overhead athletes if they had any like chronic shoulder issues. It might potentially help you activate the right muscles during daily activity or sports, and it might potentially help speed up some recovery. It's also important to point out that there are many different types of therapeutic taping, but the two that I wanted to kind of focus on today were the two of the most common types that you see are your rigid sports tape that you see a lot of people wrap around their ankles, like before playing or things like that, or after an ankle injury, as well as your classic like kinesio tape, the one that comes in many different colors and tension lengths and things like that. So first I wanted to also mention, kind of what I wanted to just touch on is like your rigid sports tape, which I think has slightly more efficacy based off the data. It's shown that it can be beneficial for providing some short-term stability for your ankle. There was some cross-sectional studies that were performed on soccer players where they analyzed like some of the biomechanical effects of rigid sports taping on plantar flexion and inversion, which is essentially just rolling your ankle in, which is the most common mechanism that people sprain their ankle. And they've shown that there was some biomechanical benefits, but they found that these were very short lasting. And when I say short lasting, I'm talking about less than 15 minutes. And they found that after 15 minutes, there was no difference between the control group as well as your ankle brace. And then there's also been some data that some of your rigid sports tape, like some of your McConnell tape, can help reduce some anterior knee pain, especially when you're doing any kind of squatting or some kind of resistance training, if you've had any issues of chronic anterior knee pain. So the next type I wanted to touch on was kinesio taping. So kinesio taping, if anyone out there is taken any kind of taping course, if they've been had it applied on them, there is like a dogma or like the way you're taught is like it can help facilitate or inhibit certain muscle groups depending on if you go from like the origin to an insertion, or if you go from like insertion to an origin. It's the thought process that helps facilitate or inhibit depending on what your goals are. But currently, if you, just take a step back and think about it rationally in the sense that, how is like a deeper or a lot more powerful muscle supposed to know whether it's supposed to be, quote unquote, inhibited or activated just based off of the tension applied on the skin? Because currently there is no solid data that supports that you can facilitate or inhibit muscles based off of any kind of taping technique. So I want to also kind of take a step back and really talk about how a lot of these early therapeutic taping techniques really became popularized. One of the reasons why was because they relied, especially early on, too much on a mechanism-based theory on why it could be beneficial or to justify the intervention. And what I mean by that is using really like physiological explanations of You know, it can provide joint stability, it can improve blood flow, it can improve proprioception and things like that. However, I think in order to justify using something consistently in clinical practice, I think you need a combination of the science-based theory as well as the evidence behind it. Obviously, it's important, you know, to start with the scientific theory on why we think something might or might not be beneficial. But that theory, I don't think holds a ton of weight until you have documented, reproducible evidence that that theory has some ground. And a lot of these early therapeutic taping techniques really became popularized based off of the theory and mechanisms without the quality of evidence to support it. And the reason why I say quality is because there have been a ton of research done in this area, but in order to find like a solid study or a group of studies that didn't have a lot of confounding variables, that actually used control groups and also didn't have selection bias was tough. Because when you kind of weed these out, when you look at these large systematic reviews, which again, by no means are they perfect in themselves, because there is a slight publication bias because they take out some of the negative trials. But when they account for equality and they get rid of some of the poorly controlled trials, they didn't find any difference in terms of proprioception, pain, or any kind of like injury prevention, regardless of the taping technique, style, or the experience of the person applying any kind of therapeutic tape. You'll see a lot of anecdotal cases out there, which again aren't necessarily the worst thing in the world, but doesn't qualify as evidence when you look at like a larger body of knowledge. So again, I know I'm being really negative, but in all honesty, in the end though, like if a patient or if an athlete, like they say like, hey, on their own, they love the tape, they do it on their own, they swear that it helps them, they swear that it helps them get through the games pain-free and encourages movement, encourages them to strength train and things like that, I won't necessarily like stop them. But I don't think using a solely like biomechanical or physiological explanation to create a dependence on the therapeutic tape is necessarily supported by current evidence or in the best long-term interest of our patients. And these are just some of the references. And a lot of these articles are open source in case anyone's curious in doing any kind of like further reading. And does anyone have any questions?
Thanks, Rushi. I appreciate it. And that was great. And, you know, I think we see a lot of our athletes on TV that utilize taping right now. So as the youth start to have some aches and pains here and there, and they see an athlete with taping on their shoulder, I think they then think that this may be a good option for them. If you became a believer in taping, is it reasonable to do yourself, or can you learn how to tape in the home environment, or should you seek a medical professional or healthcare provider that can adequately teach you how to do it, despite some of the literature, despite what you said on some of the literature? I mean, is there a form or a realm to learn how to do it properly?
Right, that's a great question. I actually encourage most of my patients or any athletes, if they love the tape, I encourage to do them on themselves, just because similar to what literature tells us, it really necessarily doesn't really matter how you apply it. It's a matter of like comfort, as long as it doesn't limit any kind of range of motion. I'm like, hey, we'll kind of go through it, we'll do a trial run, and then I'll have, as long as they can demonstrate once or twice on their, in front of me, and they said, okay, this feels good, I'm like, all right, you're done. So it's more a matter of like comfort, and it's a matter of like, again, not limiting too much range of motion. And as long as they can have really those two things, I encourage, and most of the time as to them to do it on their own, definitely.
Are you aware of any like certification or specific training for taping for an athletic trainer to utilize, or is it, or how do people that are taking care of athletes to learn how to tape if they don't know anything about it?
I would say, just from my understanding, kinesio taping is probably the biggest realm. There's like certain levels. I can't name off the top of my head, but there's certain levels of like certification or training, but I don't necessarily think you need one. I think it's more like specific for those who are interested into diving more into like, I guess, the depths or the nuances of the technique according to, what they kind of preach.
And I've got two more questions for you, sorry. And these are coming from, they're coming from the live stream. Is there a difference in the color that you see some of the athletes wear, or is that just all preference?
So it's a combination of, there has been a slight, like some different colors are supposed to have different varying tension lengths. But I think they change so frequently that it's hard to know exactly like, oh, this one's definitely more tension. A lot of it is just playing around with it in terms of determining like, okay, this one has a little more tension, it's supposed to have a little more pull. I believe the darker colors have slightly more tension as a rule of thumb. But in terms of like specifics, like this color is exactly this much more tension, I actually can't name that off the top of my head.
Is there any harmful effects that you can see with taping?
No, not necessarily. And that's the reason why, like, you know, if someone says they love it and hey, they swear by it and this helps them get through all the practices and their games, just because there's really no harm, I'm not going to stop them. I'm just going to encourage them to just continue doing it on their own if that's something that they prefer.
Great. And last question, taping ankles, do you, versus ankle bracing, if you have ankle instability, do you have an opinion on that? Because I think a lot of times parents and pediatricians are always wanting to know about taping ankles,
Right.
Or wearing an ankle brace. Do you have any thoughts on that?
Yeah, so similar to what a lot of the literature like touched on when they did the crossover studies within soccer players, the taping was very short-lived. The ankle brace was slightly longer, and I believe it was like around 45 minutes, but then they found that after that 45, maybe up to an hour, there was no difference between the control group, ankle bracing, as well as ankle taping. So short-term effects at the beginning of the game, sure, but long-term, it's really doesn't make much big of a difference compared to just not using anything.
Great. Well, thank you very much. I appreciate it.
Thank you.
Good morning, everybody. My name is Jane Chung. I am a pediatric sports medicine physician here at Scottish Rite, and I will be speaking about cryotherapy. I have nothing to disclose. All right, so I wanted to first start off with the history of cryotherapy as it dates back, even back to 2500 BC. So it's been documented in 2500 BC that Egyptian physicians used cold compresses to treat infection and injury in their patients. In 400 BC, it's been documented that Hippocrates used, for his wounded soldiers, he would put them in snow or ice to help control their bleeding and their pain. In the 1700s, Napoleon's surgeon has been documented to use extreme cold to treat cold therapy as an analgesic or anesthetic for his wounded soldiers. And in 1970s, Professor Yamauchi from Japan, also known as the father of modern day cryotherapy, realized that his patients with rheumatoid arthritis, when they would return back from winter holiday from the cold mountains, started to report that their joint pain was significantly reduced and improved. And so he actually started with the modern day cryotherapy building whole body cryotherapy, which we will talk about later in this talk. So what does cryotherapy mean? So the root word cryo comes from the Greek word meaning cold, and therapy means cure. And so basically it's body cooling or cold therapy for therapeutic purposes to help decrease pain, inflammation, swelling. It can either be used locally, so to a specific joint such as the elbow, knee, shoulder, or there's also partial or whole body cryotherapy. Methods are various, and you can use ice packs, which is the most commonly used in our athletes, ice towels, cold water immersion baths, such as this scene right here that we also have in our physical therapy facility, inflatable splints, and refrigerant gases, which are used as part of whole body cryotherapy. The exact pathophysiologic mechanisms is kind of difficult. There's some discrepancies and difficulties explaining it behind the full effects of cryotherapy, just due to the various heterogeneity of various soft tissue injuries and the different cellular mechanisms at those levels. So what are the effects of cryotherapy? So most commonly it's used for analgesia, right? So cold-induced analgesia. is a very common modality for why cryotherapy is used in the sports realm. It helps slow down nerve conduction and helps decrease pain to that area. From a vascular standpoint, we have this vascular response, and this is a little bit more complex, but in general, it causes vasoconstriction of the peripheral vessels due to the reflex sympathetic activity, hence leading to decreased peripheral blood flow to that area, helping decrease hematoma formation, edema, and soft tissue swelling. And from a metabolic standpoint, it does lead to hypometabolism and leads to decreased inflammatory responses secondary to that decrease in the metabolic enzymatic activity. So what are the indications? We use it acutely in the acute inflammatory phase, usually within the first 48 to 72 hours after an injury or trauma. Cryotherapy is also frequently used in the repair phase, up to 6 weeks post-injury, and then in the remodeling phase, 6 weeks to up to 12 months from an injury as well. The complications are very few and rare, but you do want to educate your patients regarding frostbite and possible nerve palsy, especially when just ice packs are applied to an area of injury. I always tell them, apply a thin towel and then put your bag of ice on top of your area of injury, and don't apply for more than 20 to 30 minutes, as you can get, ice burn to the skin or frostbite. There have been studies where patients can get nerve palsy if the ice bag is just applied, for several hours to an area of injury, such as the elbow. So you do want to educate them about that. Contraindications for cryotherapy. So you never want to use cryotherapy prior to vigorous physical activity or exercise, because it does stiffen the collagen fibers and lead to muscle inflexibility. And also, you don't want to use it in patients who have cold sensitivity, such as those with Raynaud's or cryoglobulinemia. So cryotherapy is definitely a very popular modality used in sports medicine. We use it very frequently and encourage it, and it's commonly used, for acute and overuse-related musculoskeletal sports injuries. And so there are some studies that have been published, mostly looking at ankle sprains, where they have studied those athletes who received acute cryotherapy acutely after an injury versus those who received heat therapy or delayed cryotherapy. And several of the studies have shown that those athletes who did use acute cryotherapy, so meaning, acutely right after their ankle sprain, did tend to have a faster return to play. One study has even showed up to 15 days faster return to play than those athletes where heat therapy or delayed use of cryotherapy was applied. It's often commonly used post-operatively as well, frequently after ACL reconstructions. You can see this patient in the picture having a game-ready splint application where cryotherapy is delivered through that splint. And so studies have shown with ACL reconstructions that it can significantly help with pain control. Those patients who do use cryotherapy postoperatively, particularly in ACL patients, have been shown to use less opioids and pain medications, and it also helps with swelling and range of motion as well postoperatively. So next, I would be remiss if I don't talk about whole body cryotherapy in this talk. This has become a very popular, cool trend over the past decade. And so is it just a cool trend that lacks evidence, or does it actually really provide benefits? So when I just did a Google search on cryotherapy locations in Dallas, I got a bunch of hits. And when I did a search within 5-mile radius of our facility here, you can see, 5 locations just popped up. And so it's gained a lot of popularity. A-list celebrities in Hollywood, professional elite athletes such as LeBron James, they're all using cryotherapy post-training, post-games, and so it has definitely become a very popular modality, especially in celebrities and athletes. So what exactly is it? So it is a brief full body exposure to dry air at cryogenic temperatures, very, very cold. So -10 to 140 degrees Celsius, which is up to -220 Fahrenheit, for about 2 to 4 minutes. And you are in this nitrogen-cooled cryo chamber where you have liquid nitrogen kind of fluxing up and down through the pipes that are within these walls. The patient is minimally dressed, so you're usually just in a robe, socks, gloves, a headband. You want to make sure that all sweat is removed prior to entering the cryo chamber, and the patient can leave the chamber at any time during the therapy. It's important to note that it is not FDA approved and regulated for safety and for how effective this device is to treat medical conditions, and any patient less than 18 years of age does need parental consent. So what does it claim that it can do? So there's claims that it can help with muscle and joint pain relief, especially in those patients with rheumatoid arthritis or osteoarthritis, can help with the pain and fibromyalgia. It's been documented that asthma patients have received relief in their breathing. It can help with Alzheimer's, multiple sclerosis, migraines, weight loss, mood, energy, and even skin rejuvenation. So lots of claims that whole body cryotherapy states that it can help with in the market. In sports medicine, we see a lot of patients who come and say, hey doc, what about whole body cryo? My son had this after his game. We think it really helped. What are your thoughts? Well, currently it's thought that it can help enhance recovery after injuries and strenuous post-exercise. And the thought is that, it's counteracting the inflammatory symptoms from overuse, and hence decreasing pain and helping the athlete get back into previous performance levels. So as we always like to look and see what are the evidence that's out there, what does literature say, because we want to provide evidence-based knowledge to our patients. And so this was a really nice review of literature that was published a couple years ago in 2017 in the International Journal of Sports Medicine, where Rose and her colleagues did a literature search looking at various databases. And they found 16 articles, 10 of them were lab controlled, and 6 were in the applied study setting where they actually assessed patients during training periods. And so these articles looked at whole body cryotherapy. Is it effective as a recovery technique after exercise? And so these studies looked at various subjective pain measures after exercise with cryotherapy. Some measured functional and performance measurements looking at mean voluntary contraction of the muscles, which 9 of the studies looked at. Some of them measured inflammatory markers such as TNF-alpha, and some measured cortisol and creatine kinase levels, looking at the inflammatory markers. 10 of the articles looked at highly trained athletes, and 6 of the articles just recruited healthy, physically active adults. Most of these studies were very small, so the N was a mean of 13 in each of the studies, and I believe the largest study had an N value of 26, so very, very small sample sizes. So overall, what did these studies kind of find? And so in terms of recovery after exercise, so overall, both the lab-controlled and applied setting studies show that whole body cryotherapy may be successful in enhancing mean voluntary contraction of the muscles and helping the athletes return to their pre-exercise strength at a faster rate than the control conditions where they did not receive cryotherapy, whole body cryotherapy. It's also been alluded that whole body cryotherapy may dampen the inflammatory cytokine response, hence accelerating recovery post-exercise because of the decrease in secondary tissue damage, so decreased CK levels, cortisol levels, and inflammatory markers. And overall, there's been a suggestion that if used, it may be dose dependent. So multiple exposures of 3 or more sessions of at least 3 minutes immediately after the exercise or physical activity and in the following 2 to 3 days post-exercise seem to yield the most consistent results in terms of pain and tissue recovery. But there are a lot of limitations and future research that's needed. So all of these study designs vastly differed. And so the difficulty and inability to blind for recovery treatment also was there. inability to eliminate the potential placebo effect as well. Also, the analysis of the muscle function parameters were all varied and inconsistent. And there was also a lack of standardization in the protocols for the whole body cryotherapy in terms of the temperature they use, the timing, the frequency. And so really larger controlled studies are needed to determine the impact of whole body cryotherapy on muscle recovery after mechanical overload in our athletic populations. And so, does whole body cryotherapy help? It may not. We're not really sure. As you can see, there are some suggestions that it may help with recovery and return back to sport, but a lot of studies still need to be done looking at a more controlled, larger setting. These are my references. And are there any questions?
Jane, that was great and a great review. I would, one question I have for you is, I understand that kids less than 18 need a parent's consent, but is there an age in which cryo would be more appropriate at, or an age in which we should not do whole body cryo because of the effects of the physiologic effects to their growing body?
Yeah, that's a really good question. So, and I think obviously, it is not FDA approved in terms of safety and for benefits, but when I have a patient who's 16, 17, 18 asking, hey, should I try whole body cryo to see if it helps with recovery after tournaments or whatnot, as long as they know that, it may or may not help, and it's actually very uncomfortable. So I've actually tried the whole body cryotherapy and I was only able to last a minute because I felt that my kneecaps were about to shatter. It was so cold. And so it is not a very comfortable thing for many people. And so I think for, the collegiate patients or, in our older adolescent athletes who want to give it a try, and you are educating the parents and the patient that there's no real evidence that, it may possibly help decrease inflammation and recovery, but it may not. As long as they're aware of the possible side effects and they are well educated enough and informed, I think it's fine. I don't recommend it at all to our any of my younger patients, just because, when you're young, I think you were able to see the cryo chamber. You've got to be, adult height. You can't be 10 years old if you're in there. So I had a patient who was 10, did a cryotherapy session. They put little boxes to stack on top because she was so short to sit and stand in the cryo chamber. She actually slipped and hit her head and had a concussion and came to me for a concussion evaluation. So I don't think it's very safe for young patients. And like I said, the science just isn't there in terms of the clear benefits of whole body cryotherapy. So
sounds like we still have a lot to learn, but in the growing athlete, maybe we should still have some caution, but
absolutely.
A physically mature athlete, maybe it's to consider. Last question. Is there, you clearly told us some great values of cryotherapy. Are there specific conditions or injuries that you recommend cryotherapy for?
So, I think cryotherapy is one of the most commonly used modalities that we prescribe in our sports medicine patients. I think it's fantastic for acute ankle sprains, soft tissue injuries such as soft tissue muscle contusions, or low back strains, acute soft tissue musculoskeletal injuries. I think it's excellent. It's cheap, it's easy. There's been a lot of literature, showing us the benefits of it, cold-induced analgesia, decreasing swelling and inflammation to that area locally. And so I think it's one of, the most commonly used modalities in our sports medicine clinic for treating musculoskeletal soft tissue. And also, post-operatively, it can be very beneficial as well.
Great, thanks so much.
Thank you very much.
Well, good morning. Thanks for tuning in. My name is Jacob Jones. I'm a pediatric sports medicine physician, and I'll be working on debunking the myths surrounding stem cells and how they apply to pediatric sports medicine. so I too have nothing to disclose. So the first question is, what are mesenchymal stem cells? Well, stem cells themselves, a basic definition, are cells that come from a source that can differentiate or almost transform into another cell. They're almost, you can think of them as like a transformer type cell. All right. Now, here's what we hear about stem cells, and this is where a lot of the myths come from. They're called the, quote, holy grail of orthopedics. They have enormous potential, and someone else called them prime time. So the myth is that these are the silver bullet to pediatric orthopedics and could be a silver bullet to any type of pediatric sports medicine problem that exists. Well, let's talk about some people or some products that have similar hype and whether or not they lived up to that hype. This young man, this is a high school basketball player by the name of LeBron James. He had a lot of hype in high school, right? And I think so, he's lived up to his hype. How about this? I don't know if you recognize this. This is Google Glasses. This product was supposed to transform and digitize everything in our world. Well, I don't see anyone wearing these Google Glasses anymore, and they're no longer in production, so these have not lived up to the hype. And the last thing, colorful ketchup. This ketchup came in many different colors, and if you go to any restaurant, I think the only ketchup we see is normal red ketchup. So this did not live up to the hype either. All right, so these mesenchymal stem cells, they come from a source. You have to get them from somewhere, and the most common area to obtain these are from fat tissue. You can also get them from the bone marrow, and also just from the peripheral blood, right? Your bone marrow creates blood cells that kind of escape into the blood, and so some of those stem cells in the bone marrow can get into the blood as well, all right? Usually the stem cells are less than 1% of the total amount of cells within these tissues, okay? And so what happens is after this product that has stem cells in it is harvested, it has to go through a process where they draw out all of the stem cells from it. They add some reagents, they do some different spinning to it, they do lots of different, you can think of it as just kind of reactions, chemical type reactions, and other processes to it to get it down to the actual stem cell. And then after you get the actual mesenchymal stem cell, then you add in different reagents or different growth factors to it, and it can therefore differentiate into certain types of cells. Now, the mesenchymal stem cells can go into a lot of different progenitor cells that are important in pediatric orthopedics and sports medicine. So we could help it differentiate into a fibroblast, a chondrocyte, an osteoblast, a myoblast, or a neuron. And then you could, therefore, theoretically, make this into certain tissues, which could include ligaments, muscles, tendons, cartilage, bone, you even think maybe nerves and muscles there. So you can see how, well, theoretically, looking at all this, it has, or it could have, a lot of potential. Well, potential is one thing, but what do we actually know? Well, here are some of the uses that they've proposed, right? Cartilage injuries or cartilage defects, including meniscal injuries, osteoarthritis, osteochondral lesions, so some type of injury to the cartilage and underlying bone, muscle or tendon injuries, and they've even suggested growth plate injuries to help prevent growth arrest. All right. Well, there's been a fair amount, or I should say some studies on animals, but what has actually been done on humans? What do we actually know about this? Well, there have been some studies on Achilles tendinopathy. They've been very preliminary studies. Same thing with rotator cuff tendinopathy. Not very good studies as far as using it as a mainstay of treatment and how well it works as a treatment. There has been some studies on osteochondral defects. meniscal injuries, osteoarthritis, and with osteoarthritis, there actually has been one pretty good study where it was a randomized control trial, and they compared using these stem cells and put it inside of a knee joint compared to a placebo, and they found that those who got the stem cells actually did have improvement in pain compared to those who had the placebo injected in their knee. And then the other one that has had one decent study from it is chronic patellar tendinopathy, or you can just think of tendinopathy in general. It also had a very recent randomized controlled trial where they injected this around a tendon, and it showed both improvement in pain and in tendon structure compared to people who did not get it, had failed physical therapy, and they also compared it to some other therapeutics as well. All right. So what about pediatrics or pediatric sports medicine in general? How many studies are there out there for mesenchymal stem cells? Well, there's none, okay? So what does that mean? Well, whenever we do any type of treatment in pediatric sports medicine, we always ask ourselves a few questions. Is it safe? Are we going to cause any harm? Well, we don't really know if it's safe in this population and for these indications in kids. Is it effective? That also, we do not know. There isn't enough evidence out there to tell us one way or the other. Is it expensive? Yes, it's going to likely be very expensive, and because it's not FDA approved, insurances are not going to cover it, so someone will have very high out-of-pocket costs to cover this therapy. So, in conclusion, is there a significant role for these stem cells in pediatric sports medicine? I don't think so right now. It's really too early to tell. So we can kind of debunk the myth that it's the silver bullet. I'm not saying it's not, we just don't know yet. It's too early to tell. Is there anything that I would use this for in pediatric sports medicine? Well, I think right now I would say no, but sometimes in chronic tendinopathies that are recalcitrant to other types of treatments, it's maybe something that you would consider and talk about in very certain populations because it has proved somewhat beneficial in adults, maybe in older adolescents. You've tried many other type of therapies and it's just really getting in the way. It's something you'd have a discussion about. But once again, you'd really have to talk about the safety and efficacy of it there. Here are some of my references. And I'll open it up to any questions.
So it sounds like stem cells in pediatric sports medicine is also debunked, but
Yeah.
my question is stem cells and this term we call PRP the same? Are they different? What is the difference? And is there indications for PRP in pediatrics?
So PRP is platelet-rich plasma, and so what happens in that case, patients have their blood drawn and then it's spun down or centrifuged down and mixed with an anticoagulant so that the blood doesn't clot, which it does naturally. And then after you put it through this spinning process, you draw just a little bit of it that has kind of a concentrated amount of platelets and other healing and growth factors in it, okay? Could it have some stem cells in it, the PRP? It could, but not very likely, okay? So they're overall different products. PRP has been around a little bit longer. It's easier to obtain and produce. There have been more studies on it. The safety studies on PRP are reassuring. We know that it's safe. The efficacy studies, as in does it work, those are a little bit mixed. And I think if you do it the right way in certain circumstances, I think it can be beneficial. And even though that the studies have been mixed, I have found some benefit in my practice using PRP in certain patients.
You know, with so much marketing out there and a lot of people convincing us that stem cells are a good option for us. Is there a reputable online resource, or is there some way that families could have an understanding that they're actually getting what they're paying for? Or is there any kind of quality control within the industry at this point?
Yeah, that's one of the issues is a lot of people say they're doing stem cells, and because it's not FDA regulated and it's not FDA approved, anyone can market and say they're doing it. And so I would just say, I would use a lot of caution when people say that they're using stem cells, especially for the pediatric population. As far as like a single good resource or source that's reliable, the only one that I'm aware of is just good scientific literature in the database that I understand it's not always accessible to families, but at this time and point, my overall arching theme would just be use a lot of caution as far as going and getting stem cell therapy done for orthopedic, pediatric sports medicine conditions in your adolescence.
Thank you, I appreciate it. So I don't know about you guys, but I learned quite a bit actually during those debunkings, and I think we all can take away a few extra pearls to tell our patients. I know we're running a little late on time, but we'd still like to have a little bit of a panel discussion. We're going to make it quick, so I'm going to ask the panel speakers to give us short responses, and I'm going to try to control this real quick. So if I can get you guys to come up here, I'm going to give one extra microphone. So what I'm going to do is I'm going to spell out a patient, not a patient, your child. So your child is a 12-year-old, 13-year-old female soccer player. The coaches say that she should try out for the Olympic development team, and she's guaranteed a college scholarship. And she's on a club sport, and she absolutely loves it. She goes to practice 3 times a week and has tournaments and games on the weekend. She gets pulled to multiple teams. So I wish we were in the dating game, so there was like you guys couldn't see what the other person voted, but we're going to vote, okay, on at the age of 13, elite level soccer player, female, who is going to initiate a strength training program for that youth athlete. I want to raise hands. Awesome. Okay, Dr. Miller, do you have 1 or 2 sentences to comment on that philosophy?
No, that sounds like a familiar scenario to your household, perhaps, though. This is something we see quite a bit, and I really feel like incorporating strength training early on in this this age group, I think there's a lot of benefits, and I often will to the athlete, to get them engaged, sell it as performance, because we know there are performance benefits translate onto the field. But from a selfish standpoint, if we can reduce injury risk and get all those other benefits, mental health and otherwise, I think it's a win-win.
Great. And last question, and I have a feeling I know where everyone's going to vote on this. The coach tells you she needs some stem cell shots because that's actually going to make her perform a little bit better, and it's going to allow her to heal a little bit more. And you firmly say this is not indicated in pediatrics right now. However, aside from stem cell and PRP injections, for chronic tendinopathy in a 16-year-old soccer player, hurts around her kneecap, seems to be very classic patellar tendinopathy, would you consider, again, a little bit older, a little bit different problem, would you consider PRP injections? Wait, everyone's got to raise their hand. Any votes for a yes? Oh, wow, little half hands go up. Okay, I like it. So there's a lot of maybes there. Dr. Jones, tell us how we get our hand all the way up for the right making the right decision.
Yeah, I think I'd consider it in, the first thing you look at is if they've got some type of chronic tendinopathy, is getting them into a good rehab program and see if that does it, and also having a discussion regarding appropriate rest and sports diversification, which I know can be a tricky thing at times. But if despite doing those things, they're still having pain and they're not getting better, then I'd have the discussion as far as PRP injection goes.
Great. Well, I just want to thank all of you guys for your contributions today. I think it's extremely valuable, and I really appreciate it, and touching on some topics that not every medical professional or sports medicine professional really know the literature on. So thank you very much. I really appreciate it, and hopefully you guys can be able to look at these on demand in the future. We'll put them in different, smaller clips if you like, but feel free to reach out to us if you have any follow-up questions regarding these topics. Next month, we've got a really exciting topic looking at the thoracolumbar evaluation in a pediatric patient. Dr. Pediatric, who is one of our newest members of this team, who is really going to help take over looking at kids that have scoliosis conditions as well as back pain, and he's going to show us how to examine and evaluate lower back pain in some of our young kids next month. So stay tuned, and we look forward to seeing you guys then. Thanks, and stay safe.